Good evening, and thank you for joining us this evening on this wonderful webinar from the Institute of Sport, Exercise and Health, COVID-19, the Road to Recovery. We have some wonderful speakers tonight who are embedded clinically in this area. We've been supporting many Olympic athletes as they've been to Tokyo, and through the experiences that we've picked up working with this particularly challenging cohort, James Hull and Guido Pieles decided that actually it would be quite useful to try and transfer and impart some of that knowledge they've been working with this cohort. And so tonight we've put together what we think is a credible panel of speakers. So we have tonight Jim Hull, Guido Pieles, Julie Moore, and Oonagh Cousins. There's been a slight change to the program. We've put Oonagh last, and I think one of the reasons why we've done that is a highly valuable patient story experience of an athlete, an elite level athlete competing at the very highest level, who is making this transition back to full competition, having suffered a prolonged, protracted illness from COVID. So we'd start this evening with Jim Hull, recovery from COVID infection in athletes. What do we know? What do we do? And what do we need to know? We then move on to Professor Guido Pieles, assessing cardiac health in athletes from a COVID perspective. Julie Moore is instrumental and a key member of our sports respiratory physiotherapy team and her role within the value of physiotherapy within COVID-19. And then we move into the crown jewel of this evening's talk with Oonagh Cousins, and that is the athlete's experience. So without further ado, before I leave to Jim Hull, we've been given a whole heap of questions from you, and hopefully we've answered them as these talks go along. But if we haven't, there is a chat button. Please put your questions in there, and I'll chair them, and we'll do a Q&A at the very end of the talks. Thanks very much. Jim, over to you, please.
Well, thanks, Matt, and it's a great pleasure to join you this evening on this virtual webinar. So my task for the first 15 minutes is to kick this webinar off by just hopefully setting the scene on what we know about long COVID in athletes, and perhaps giving you a hint and a flavour of what we need to know to try and help athletes recover more effectively. Just as means of a background, for those of you who don't know me, I'm a respiratory physician. I work predominantly at the Royal Brompton Hospital in the NHS, but I also work in the Sports Respiratory Service at the Institute. I've got roles in the English Institute of Sport and for various anti-doping bodies, and hopefully of some interest to you in the audience is that I've been contributing as a guideline member or as a chair for a number of different committee guidelines on athlete respiratory health for the International Olympic Committee and for the British Thoracic Society, and they're going to report later this year. And the reason I highlight that is that these documents will have sections on COVID and assessing the breathless athlete following COVID. So look out for those, please. So what do we know about COVID? Of course, this novel coronavirus has been around now for over a year, and over that time, we've learned a lot about this in the general population. Here's what it looks like in a relatively athletic individual in a mild to moderate case, where you can see on a chest x-ray, someone with acute COVID doesn't really give a lot away in the mild and moderate cases, but on a CT scan, you can see scrolling through these diffuse, bilateral, horrible, fluffy type infiltrates called ground glass changes. And they, as you can understand, cause a lot of breathlessness, drop in oxygen saturation levels, and a lot of coughing. And that's really the key feature. And of course, the presentation at this acute phase is very much a respiratory disorder. We also know now, of course, it causes other manifestations in a variety of different organs. And you can see here the heightened prevalence of blood clots, and there's a clot there within the pulmonary artery being labeled on that red arrow. It affects respiratory musculature, and of course it affects the heart muscle, which you're going to hear a lot more about in the subsequent talk. It's a devastating disease in elderly individuals, as you've seen and heard, I'm sure, in the news and seen through the data that's come out over the past year, that for the vast majority of those who succumb to the illness or require critical care, they're over the age of 50. And yet at the same time, there is a high burden of disease in younger individuals. And whilst they may not be admitted to hospital and don't have the same type of critical care requirements, the disease has a huge impact on, for instance, ability to function. And as you'll hear in some of the later slides that I present, an impact on ability to perform physical activity in sport. One of the things that I think has come out and has been, if you like, one of the silver linings from COVID is our ability now to really understand diseases in a much more detailed fashion. Many of you will be aware of this Zoe COVID tracking app, where individuals across the UK, many millions of individuals, have entered data almost on a daily basis to track symptoms and to report when they've become unwell, how those symptoms have affected them. And this data has allowed us to build some insight into the typical duration of symptoms so that you can see that for the vast majority of non-hospitalized cases, COVID illness occurs over the course of about a week to 10 days with a median duration of 11 days based on this very long sloping off tail of individuals who struggle with much more protracted symptoms. And that's not an insignificant amount. So if we look at the data that's been published from the COVID tracking app data, and this is data published in Nature Medicine, you can see that there is this long tail, and about 13% of individuals in the UK end up having symptoms that last for longer than 28 days. And we can debate what long COVID is or what protracted or post-COVID is, but I would argue that if you've still got symptoms after a viral respiratory tract infection that's lasting longer than a month, then surely that's a huge amount of burden and an impact on your quality of life. And 28 days to me seems an important time point to think about that. You can see how that impact and prevalence slightly increases as individuals get older. So I hope that sets the scene about what we know more generally in COVID in the population. What about athletes? And I want to share over the next few slides some data that we recently published in the British Journal of Sports Medicine, looking at a really, really elite cohort of athletes. So these are athletes under the auspices of the English Institute of Sport and the home nation's sponsored and supported health system. So they're very closely monitored athletes, many of whom are preparing for Olympic and Paralympic competition. So we looked at 115 individuals in total, and you can see how that was distributed over the first and the second waves of COVID within the UK. And much like the COVID Zoe tracking app data, we looked at symptom duration, and it was remarkable the pattern really of symptom duration is actually very similar to that reported in the UK population. So we see a median of 10 days of duration of symptoms as opposed to the 11 days. And hopefully you can see that the prevalence of symptoms lasting longer than 28 days is about 14%. And in fact, if I overlay the Zoe data graph there, you can see actually they pretty much overlap when you think about the tail just being moved across in the figure from our paper. Importantly, in the athletes, there was no hospital admissions. None of the athletes required dedicated targeted treatments such as steroid from these first two waves. What's unique, sorry, I should say as well that actually when we look at the number of athletes who still have symptoms at 90 days, a much longer time point, that figure is fortunately reduced to 3% of athletes. But of course, what is unique about athletes, and particularly elite athletes, is that their sport is their living. And so we were very interested in trying to get a figure on how often it was that athletes were unable to return back to their sport and be professionally cleared to go back into full training and competition. So a big part of our data analysis was to say, look, when is this athlete signed off as being back and fully available? And you'll see from this graph here that actually that figure is much higher than those reporting ongoing symptoms. And in fact, we found as many as 1 in 4 of those elite cohort of athletes weren't signed off as being back and available for their sport after 28 days. Huge impact when you consider that against some historical data we hold for other causes of respiratory tract infection. And so this tracking system and the health monitoring system within the English Institute of Sport and others who contributed to this data set allowed us to look and compare. And what we found is that in the normal acute respiratory tract infection, non-COVID, so data before COVID, we found that there was actually only 1 in 20 individuals who were still struggling to get back to sport after 28 days. And you can see the very high bar on the far left showing that actually for the majority of individuals, the illness doesn't really impact for more than 1 or 2 days. We did a bit of deeper digging to try and understand, were there some factors at presentation that might predict a more protracted recovery? And you can see from this figure, hopefully, that when we cluster individuals based on whether their symptoms were confined to the upper respiratory tract, so for instance, a loss of smell or taste or sinus problems, or whether they were clustered at presentation to the lower respiratory tract, i.e. the presence of breathlessness or wheeze or chest pain, the lower respiratory tract phenotype was far more associated with a protracted impact on a return to sport, as opposed to the upper respiratory tract phenotype, which might actually signal out a faster recovery. So what's going on with individuals who have a protracted recovery or prolonged symptoms? Well, we know from a number of studies that have looked at this in detail in the general population that the key and cardinal three features that seem to be apparent in individuals who struggle with ongoing symptoms of fatigue, very much a key feature. And then the other two features, which certainly we've seen within our sports, post-COVID sports respiratory clinic, is of shortness of breath and of chest pain. Now, I don't want to steal the thunder of Guido, so I'm just simply going to talk about shortness of breath, really, which is the area of my expertise. And if I think about generally when I see athletes and I talk to them about breathing difficulties or breathlessness, and particularly pre-COVID, but of course in general as well, of course, any different type of respiratory disease or cardiac disease process or systemic cause can present with breathlessness and an inability to perform and perform to previous levels. But by and large, the differential diagnosis boils down to these three conditions, which is exercise-induced asthma or bronchoconstriction, a condition where the larynx closes in called ILO, or as you'll hear about later on in this webinar, a problem with the pattern or the way the breathing efficiently moves air in and out of the airways. And so these are airway-centric issues. And I raise this because they're very different from the type of issue that we might see post-COVID. These are symptoms which present often with wheeze, with cough, alongside the breathlessness. And if you just go back to one of the slides I presented first of all, these are the CT scan images and the image showing a blood clot. And those are conditions which don't really necessarily localize to the airways, they're affecting the lung tissue. So if you do airway tests, such as blowing in and out of a spirometer and looking at the way the air flows in and out, you're not necessarily going to pick where the damage might be in the context of COVID. And this is illustrated very nicely in some analysis we've done of the number of studies published looking at lung function in individuals recovering from COVID. And you can see if you look at airway markers such as FEV1 or FVC, even in those most severe cases, hospitalized individuals and those who've been taken to critical care, they don't really have an impact on their airflow parameters, and yet you can see the profound impact on measures such as the gas transfer, the TLCO. That underpins why at the Institute we've been taking measurements looking at gas transfer particularly as a really important measure to look at the function and how well the integrity of the lung has been preserved following this condition. It's also borne out by some of the studies which are now emerging, and this is a study looking at footballers following COVID. And whilst you can see that in this population who did have some spirometry performed before and following COVID, one of the very few data sets that's available that's looked at pre and post physiological measures, yes, there is a slight reduction in airway markers, but overall they still remain well within the normal range. So what is going on then if we can't interrogate the airway measures and people are still breathless? Well, one of the ways that we could look at this is to consider the physiology of doing hard and vigorous exercise. And of course, when you're performing hard exercise, particularly at the elite level, everything really comes down to the muscle functioning in the best way possible and extracting oxygen to allow the muscle fibrils to contract and provide the energy source and the propulsion that's needed. Now, in the world of physiology, we often consider a chain of command that delivers the oxygen down from the lungs, where there's got to be adequate ventilation, that bellows the oxygen in and out of the lungs, a good gas exchange mechanism, and then, of course, a great circulatory system with good amounts of blood cells which can transport that oxygen. On top of all that, of course, is what might be called the central governor or the brain, which controls the whole system or has some sort of control and feedback loops. And it's vitally important that that system is considered when we consider breathlessness, because there are lots of feedbacks which tell you whether you feel breathless and how you perceive the breathing that you're doing for a given task. So what does that look like in real life? Well, within the Institute, what we've been doing a lot of in individuals who've been breathless following COVID is performing cardiopulmonary exercise stress tests. And essentially that's a test on a bike where the intensity of exercise increases from rest, and we're looking very carefully at different measures to try and interrogate the physiological pathways and understand where there might be a deficit or a weakness. And there's lots and lots of papers now emerging on the value of undertaking cardiopulmonary exercise testing in the general population to try and unpick where the issues might be. And some papers are showing issues in the muscular extraction of oxygen. Others are showing a tendency to hyperventilation or overly exuberant breathing, which actually isn't helping an athlete, helping an individual, but is hindering their performance and also causing them to feel more breathless. Let me share an example with you at the Institute of an individual who's, we're measuring the breathing. You can see the mask on, looking at the tidal volume, and tidal volume should be a nice little wave up and down as you breathe in and out. But in this individual that we tested, the breathing pattern was incredibly chaotic and all over the place, moving up and down and moving up and down. And essentially what that means is that during the exercise bout, where you would expect what's called the tidal volume, the amount you breathe in and out, to be low and steady, you can see how chaotic it was throughout the exercise bout. And that leads to decreased efficiency of breathing and this abnormality called dysfunctional breathing. And so we've asked Julie to talk this evening on dysfunctional breathing, and we've found that a great number of people have benefited from targeted intervention to help with their breathing. So I realize this is only 15 minutes, and to bring it in on time, I'm going to just summarize some of the key findings that I've described in this opening talk, and particularly the fact that we now know, certainly within our cohort looking at elite athletes, that some form of what you might term long COVID at 28 days is present in about 10 to 13% of athletes. But perhaps more importantly, for certainly professional and elite athletes, a quarter of athletes still appear to have their sporting performance impacted and not return to normal activity at 1 month. It's a big impact. The impact is longer than other viral illnesses. And initial presentations with lower chest symptoms might be predictive of a slower recovery. Fortunately, the serious complications appear to be rare, and there's no data set showing fibrosis or emboli in athletes to date. And as I've said, the breathlessness doesn't appear to overlap with other causes of breathing difficulties that we commonly see in athletes, such as airway-centric issues. What do we need to know? Well, a lot more is the simple answer, and you'll notice that I've deliberately skewed this talk not to give you too much in what we need to know, but I would say that we certainly need to know about the relative contribution of peripheral versus central issues in terms of the physiology that I showed you, and the interplay with the cardiac systems, and particularly the autonomic nervous system, which I know Julie's going to talk about. How does fatigue interface with breathlessness? Because as you'll hear from Oonagh, those two things are very closely linked. We need to look at biomarkers to try and aid assessment and surveillance, and of course we're always working to try and find the best treatments to help people. I'm going to stop there. Thank you, Matt.
Thank you, James. We've had a few questions come in, and we'll take those at the end. And so I think, moving swiftly from a respiratory perspective, I think, Guido, if we bring up your cardiac talk, and then we'll move on to physio, and we'll wrap all the Q&A up at the end. So keep your questions coming in, please.
Thanks very much for coming online for this seminar. And we talk about cardiac and COVID. And what I would like to say is that COVID in itself is not only a medical scientific problem, it's of course a political and a policy problem, and it's inevitable. And with all these decisions, we must never forget that we are medical professionals who are trying to help the individual patients. Here are my disclosures, which hopefully can show you my passion for sports cardiology. However, I would like to highlight the last one. I'm an advisor and have been for various issues in terms of COVID and cardiac, including the vaccinations. And it's obviously quite clear that what I say today is my personal professional opinion. And I will talk about vaccine-related myocarditis in one slide. But let's start with cardiac involvement in COVID. What do we know? What were the first stats we had? And here I refer back to the earlier papers, and that's what I've shown in a webinar almost a year ago. And this showed a staggering 25% of non-athlete COVID patients that show cardiac involvement. This was, of course, a very high number, but these patients were hospitalized, and this data had to be taken with a pinch of salt. And again, the 62% of non-athlete autopsies that show myocardial viral replication was extremely worrying. And you will know this as sports scientists or anyone who works in the medical sports profession, that it was quite unnerving, and we didn't quite know how to protect our athletes. However, as more data came in, it has now been shown that cardiac involvement from COVID is probably much lower. And while some earlier mice studies found involvement from 2 up to 46% and even higher. The most reliable studies I will show you as well show that in 0.7 to 2.3% in COVID positive athletes, and this is US college data, several thousand athletes, there is cardiac involvement. So around 1% every 100 athlete that has COVID has a cardiac involvement. This is somewhat reassuring. It's not a pandemic in itself, cardiac involvement, but we need to be careful because what cardiac involvement means is myocarditis very often. And you will know myocarditis is a common risk factor for sudden cardiac death in our young athlete population. And that's we are so keen to do everything possible to exclude myocarditis, or if we diagnose it, to take preventative measures. In young athletes and in children, I need to mention there is this rare pediatric inflammatory multisystem syndrome. This is single numbers in 100 per 100,000, so it's extremely rare, but this can present with coronary artery pathology, heart failure, arrhythmias, and unfortunately in some cases with sudden cardiac death. However, this is extremely rare. So how's our approach towards COVID-related myocarditis and other cardiac involvement? How do we diagnose it? Well, there are several guidelines and position statements come out, and I think these three are still very relevant, and one of us was spearheaded by our own Matt Wilson, and these were done mainly in early 2020, and of course I get a lot of questions from many healthcare professionals. Can we still use them? Are they still valid? And I will go into this, but I want to show you then also what is new and how we practically assess an athlete. This is rather small. I'm so sorry. I hope it's bigger. For me, it's small, but I know this paper. And what I want to show you is several things. One thing is, has really much changed? We say it, and this is our paper from the Institute. If you assess an athlete for cardiac involvement with COVID, if the athlete is tested positive for COVID, is asymptomatic, completely asymptomatic, then no cardiac tests are necessary. And this is the first message. Yes, I would still say this is the case and this should be done. The other important thing is, and here my box is not quite fitting, it did before, and this is really, if someone has mild symptoms, I can go out again for you to read it. If someone has mild symptoms, then 7 days or 1 training week rest is still an important message. This should be adhered to. If it's 5 or 6, I don't mind. And we say here 10 days after the onset of symptoms. This is debatable, but one should rest after COVID because we know from clinical experience, but also from emergent data that cardiac involvement is more common if athletes don't rest, if they have even mild symptoms from COVID. The other things that have changed is probably that should an athlete have symptoms, be it palpitation, dizziness, syncope, then they should have a 12-lead ECG and an echocardiogram. Echocardiogram is not very sensitive, but these should be the first-line test. But then, should there be any abnormalities or symptoms, then all the other tests should be done, which is a 24-hour ECG, also troponin, a cardiac MRI, and an exercise test. A stage approach, for example, doing an exercise test and maybe doing then an MRI scan, I would not advocate. Once there is a clear indication that there is cardiac involvement, we need to test. And I tell you why in particular we need to test with MRI. And this basically says the same. Here, it might be small as well. Here, this is also something new. This is a study by John Dressner and Kem Harmon in Seattle, who looked at 20,000 athletes and 3,000 tested positive. And then they looked what tests should be done. And if you cannot read it and it's too small, then this study was very important to clarify that in 0.7% of athletes that tested COVID positive, there was cardiac involvement. Not necessarily myocarditis, but maybe some arrhythmias, maybe chest pain with ST changes on the ECG, or myocarditis. And the other important data that came out of this study is, if MRI, cardiac MRI, is used judiciously and is used in symptomatic patients, then the diagnostic yield is very high, because there were previous papers who did MRI in everyone and every athlete, and they found conflicting changes, and it was not quite clear. So this paper clarified this. However, the next paper that came out then did actually do cardiac MRI in COVID-positive athletes as a primary test. What they've shown here is 2 things. Firstly, if you don't test, then you miss myocarditis. If you test only a little bit, for example, an ECG or troponin alone, you might miss it as well. If you include clinical symptoms, echo, ECG, and above all MRI, then you diagnose most of the myocarditis cases. But one interesting fact was also that if you throw an MRI, a cardiac MRI at every athlete, then you diagnose a higher number of myocarditis. So I have to here criticize the paper a bit because they conclude, well, we should do an MRI in every COVID positive athlete. I don't think this is important. I think we should go by symptoms and by primary tests, which is ECG and echocardiogram. And if this is positive or their symptoms, then an MRI should be done because we can also have false positives. The MRI shows you edema maybe and a little bit of cardiac dysfunction maybe, but does this mean there is clinical myocarditis? And this is of course important for athletes. So what is new? The last new thing I want to show you, and you've heard it in the news, is really the COVID vaccine-associated myocarditis. And this is very rare. This is MIHA data. You can look at this online. So the overall incidence of vaccine-unrelated myocarditis is probably 100 cases per million, probably more. And vaccine-related myocarditis, the incidence is much, much lower. Plus, importantly also, when we talk about vaccine-related myocarditis, it does not mean a full-blown myocarditis with arrhythmias, with sudden cardiac arrest and all these things. These are case definitions that are very mild. For example, someone after vaccination with chest pain and a high troponin comes to the GP. This is locked in our yellow card system as myocarditis. So the message is here for adults. I think there is a lower risk of vaccine-related myocarditis than of myocarditis related to COVID. And this is obviously important for vaccination rates. And I know there will be further announcements targeted at athletes over the next weeks in terms of vaccine and myocarditis. At present, there is no hard data to show that there is a huge risk. However, what does it look like? And in children, it's a bit of a different thing. There's some case studies in children. And what I want to show here is that in these case studies, 100 cases altogether, 90% of these children or young teenagers, which can also be our young athletes, have gadolinium enhancement, meaning fibrosis on the MRI scan in the acute phase. This is indeed concerning. However, we do not have any follow-up data. There is no death, no arrhythmias that are sustained. So we need more data here, but I would closely watch this space. So what do I do with my athlete? What are the diagnostic tools? As I said, clinical examination and disease history is paramount because this is a risk factor for myocarditis. Pre-syncope, palpitations, chest pain, of course, during exercise particularly. This is an ECG. This is from the American paper. This is a normal athlete with early repolarization. I hope you can see this. And this is an athlete with myocarditis. There's also early repolarization. These are almost identical athletes, and I would not ask you to be able to differentiate between them. I would be hard pushed. Here's an ECG from one of our patients, and you can see there are very mild ST changes, and they're extremely difficult to diagnose. And that's why it's so important to do a range of tests. Of course, it's always useful to have old ECGs and compare, and that's why we made the diagnosis here, because the previous ECG looked normal. Echocardiography, of course, it is not very sensitive in myocarditis alone, but is a baseline tool. And if you send an athlete for an assessment, then he or she should have an ECG and an echocardiogram. And what you sometimes see is, if at all, a reduced strain, so reduced myocardial malformation, deformation, which is a sign of myocardial dysfunction. Subtle changes, but sometimes you can see this as in this athlete here, but not very sensitive. So what about return to play? And this is obviously very important. 7 days rest is very important. However, if there are no symptoms and tests are normal, then a graded return to play can be started. If, however, any findings in the ECG and the echocardiogram, then tests such as troponin, CMR, as I said, exercise stress, and Holter monitoring should all be done at the same time. Troponin should be done with at least 24 hours rest after exercise. Otherwise, we get abnormal findings. And then MRI. So if these tests are positive, and here is another big thing we've learned and we are learning. Normally, we say myocarditis requires rest of 3 to 6 months. However, if you've got very mild changes on the MRI, the exercise test is normal, there is no arrhythmia risk, then I do not think an athlete needs to rest 3 to 6 months. But this requires careful follow-up and longitudinal follow-up. It's extremely important. We cannot just assess an athlete once and then send him out to your care often and see him again 6 months. My opinion is that we need to really accompany the athlete and the club and the sports scientists and medical team and see the athlete regularly. But then I do not think we need categorically say 3 to 6 months rest. Return to play can happen earlier. Secondly, diagnostic tools, of course, MRI scan, and I told you that there are papers who said in the beginning 78% of MRI abnormalities in COVID and all this. So this was a bit Wild West. I do not think this is true. We probably say now there's 1% to 2%. I've shown you the papers as well. What you see on MRI is mild gadolinium enhancement, which can indicate fibrosis and also edema in the heart. And if MRI scans are done, then they need to be done with a modern technology such as T1 and T2 mapping, where we can clearly see edema, meaning there's active myocarditis. This also means that there's an initial MRI scan, but there might be another one to be done in 2 to 3 months' time. And then stress ECG or mobile ECG monitoring is paramount. Every athlete with suspicion should be investigated during exercise. And as you can see here, there's a ventricular tachycardia during exercise. And this is, I would say, the most common diagnostic pickup we have, apart from the MRI. If arrhythmias during exercise, they might even be symptomless. And the other thing is, of course, mobile ECG monitoring, because the athlete can train in his or her environment. So these tests ought to be done. If suspicion of myocarditis or cardiac involvement, then I'm afraid we need to really, because it's so difficult to diagnose and there's such a, albeit rare, but tangible risk of a sudden cardiac event, these tests need to be done. What we do often as well is stress imaging, because often the cardiac function at rest is normal. We have got an echo machine, we can do CPET, and we can image the heart during exercise. And we do this particularly if the ejection fraction, meaning the cardiac output, the function at rest, is reduced. Then this is a very valuable tool, because in active myocarditis, often the exercise, we call it myocardial reserve, is not increased during exercise. So all I want to say, so in summary, cardiac involvement in mild to moderate symptomatic COVID even is very rare. 1 in 100 athletes with mild to moderate COVID has cardiac involvement. However, it requires a multimodality approach, and it requires also, particularly in athletes who would like to return to play very quickly, a longitudinal approach. More so, fully asymptomatic athletes who are just tested positive, I do not think need to have a cardiac assessment. It's an important message as well. And then really there needs to be a proper use and a well-informed use of diagnostic tools, particularly to avoid false positive results. I've seen also athletes for second opinion that have been put at the sideline with, in the end, normal findings. Exercise stress is an important assessment tool, and if you ask me to test, it would be an MRI scan and it would be an exercise test that these athletes need to have, because the MRI is gold standard. And sufficient resting period is paramount. If you want to do your athlete a favor, let him rest for a week. He will be, or she will be, back sooner on the pitch or in the competition arena. Thank you very much. I think that is all I wanted to say tonight.
Thank you, Guido. Appreciate that. And you've answered a couple of questions that I've been noting down. So, we'll tally them up at the end. And then we move on now to Julie Moore. And Julie is part of the sports respiratory team at ICH. And I must say that when I came into this role, I have an enormous appreciation for physiotherapy, but I didn't appreciate just how much I appreciate respiratory physiotherapy now. So Julie, the floor is yours now, please.
Thank you very much, Matt, and good evening, everybody. So I'm a respiratory physiotherapist, and I think my role comes in with the team is when the athlete has gone through the investigations that we've been talking about, and everything's good, everything's great, lungs are okay, heart's okay, but yet they're still experiencing symptoms of fatigue, breathlessness, possibly even chest pain. And as Dr. Hull touched on, may have recognised that the athlete is dysfunctionally breathing. So it's absolutely sort of essential for me to be able to help the athlete, educate them, and look at strategies that will enable them to recover from these symptoms. So for me, this next 15 minutes, I really want to give you some management strategies on what you can do to help your athletes or help yourself to recover. And I think breathing recovery obviously is absolutely essential. This is something that I feel very passionate about, and I'm keen to tell more people about it because I think it's really important. So obviously breathing is automatic, but it's influenced and altered by lots of different things, which can really hinder recovery and give quite nasty symptoms that we're seeing. So my question to you is, are you breathing optimally, or is your athlete breathing optimally? Because it really can help with the recovery from COVID. So to get started there, let's look and see possibly what happens with breathing when you experience COVID. And I often go back and educate the athletes in reminding them about the sort of, go back to basics, looking at the autonomic nervous system, because we often see a real imbalance between this system. So we know that when you suffer with the virus, the sympathetic nervous system is vital in recovering from the virus. But sometimes what happens is after a period of time when the acute phase of the virus has settled, we often see that the sympathetic nervous system is continue to be stimulated. And that parasympathetic, because it's a balancing act, the parasympathetic nervous system is often diminished. And that's essential to get that repair, that restore, that recovery from the virus. So looking at potential dominance of the sympathetic nervous system is really important, and it manifests in a lot of ways, but specifically around breathing. And what we see with people with a dominant sympathetic nervous system is usually a really inefficient breathing pattern and an inability to really let go and rest and recover. So often say they're not sleeping very well, just not able to recover from one session to the next. And so this cycle often becomes, really predominant. And what I want to do is to help athletes to be able to show how can you stop that cycle? How can we really help to recover from the virus? And this is a graph looking at, we actually got to measure the autonomic nervous system in a few individuals with long COVID. And this is actually the ideal. This is what you're looking for. Looking at a 24-hour period of time. The red is the sympathetic nervous system in the day, and the parasympathetic at night is in the green. So lovely. Red in the day, green at night, good recovery. It's absolutely essential. And you can see there, I'm not sure how easy you can see, but leading up to bedtime, you get a nice parasympathetic nervous system coming into play. So 8, 9, 10 o'clock. So the body's preparing itself to go to sleep and rest and recover. And what you'll see there is a nice high heart rate variability showing that the person has had a good day, they're recovered. And that's, as I say, what we're looking for. But what we often see in people, athletes suffering with ongoing symptoms of COVID is this predominant sympathetic nervous system. So this is someone over a 24-hour period where they've lost their parasympathetic nervous system. They've gone to sleep. They thought they've slept, but the quality of sleep hasn't been good. And if you see there, a very low heart rate variability shows that the person hasn't recovered. And this is someone that has had investigations. There's nothing medically causing these issues. This is someone that's not sleeping properly, not breathing properly, not resting, not relaxing. And so this is the type of breathing pattern you see on the left there that we see a lot when we talk about this dysfunctional breathing pattern. You can see there that that green dome shape is the diaphragm, and that we get this predominant upper chest breathing pattern. So you see the shoulders rising and falling, whereas what we really want is a much more efficient breathing pattern where the air is going to the bottom of the lungs. That's where the perfusion is. That's where we want, to get a good ventilation perfusion match. It's absolutely essential. And the consequences of that inefficient breathing pattern, as you can imagine, overuse of the rib cage, at rest can cause discomfort in the sternum, in the intercostal muscles, that can bring on the chest pains. It causes the breathlessness, causes chest tightness. you know, the amount of energy that's used in that type of breathing pattern, you're looking at possibly 20-30% more energy. You think about how many times you breathe in a day, a lot of energy is wasted. And this is why it often can link in with that fatigue side of things, and that inability to be able to recover and really working off a very low battery. But also what we've seen in some is potentially the hyperventilation side. So this is where someone is breathing in excess of their metabolic requirements and start to really get drops in their CO2 levels, which can have quite a significant effect on blood perfusion. See there in the brain there, and we think about symptoms that people experience with hyperventilation syndrome. It's very similar to the symptoms that people experience with long COVID. So I kind of want to bring you back to basics. It's absolutely essential that we are looking at breathing pattern, understanding what can go wrong with breathing. As I say, you sort of just presume it's automatic and it will sort itself out, but it often doesn't. And it kind of starts with the nose. The nose is absolutely essential. I'm talking about at rest here. I'm not talking about when our athletes are at their high intensity exercise, where mouth breathing is obviously essential to get the oxygen and carbon dioxide out. But I'm talking about at rest. And we do see, you know, when you're experiencing the COVID virus, that there does tend to be this mouth upper chest, because the mouth it's easier to breathe in and out of the mouth. But the nose is important for cleaning the air, warming the air, humidifying the air. You know, it's your natural mask of the world. And so if you see someone that, or if you notice that you mouth breathe all night long, again, you might be driving that sympathetic nervous system, stopping your body from being able to get a good quality night's sleep. But the nose is also important to get that natural diaphragm pattern, because again, the air tends to, in the mouth breathing tends to go to the upper part of the chest. And so then it's a waste of energy. But what I also see is often a very fast breathing rate. And you can breathe at sort of, you know, 20 breaths per minute, bearing in mind the normal is say 10, without really noticing anything. So you wouldn't necessarily notice someone. So it's really quite subtle, some of these breathing changes that I see. And so what sometimes you see is that the breathing pattern is, you know, there's no pause in between the breaths, and there's no sort of rest. And again, this is something else that can drive the sympathetic nervous system and stop that, you know, diminish the parasympathetic nervous system. The tidal volumes, you know, remember breathing at rest is small. It's actually, you know, I think we get a little bit excited about doing lots of deep breathing, big breaths, and in actual fact, half the time I'm getting the athletes to breathe less at rest rather than more. So really important to get that minute ventilation right. So a lot of things that I can work on with the athlete, with their breathing just at rest, which can really help to promote that parasympathetic nervous system. And so I'm often getting the athletes to understand the importance of efficient, slow breathing. And I think we do use this term deep breathing, which I think sometimes can be a bit misleading, because I think for some people, deep means big, and for some people, deep means low down. For me, it's that low down, it's that diaphragm breathing that's important. And it's the slow diaphragm breathing that's really important in getting the parasympathetic nervous system back in action and slowing the breathing down at rest. And so we know that we can also influence the parasympathetic nervous system through relaxation. And so I'm often finding out more about the lifestyle of the athlete and how they're getting to relax. So I ask them how they relax, and they might say to me, they watch TV, or, you know, they do video games or whatever, Xbox. And in actual fact, that's not relaxing. There's a difference between downtime and relaxation. I'm talking physiological relaxation. And this is a tool that we can teach our athletes to be able to help. This will help in terms of recovering from one session to the next, but really important post-COVID, because it enables the body to get the good quality sleep. It recharges that battery. That analogy with the low battery really helps to recharge. So I'm often having to really look at getting the rest and relaxation right in combination with the breathing. So, you know, looking at fatigue management, again, I think my role is to help the athlete to understand the whole of the energy system. I think we know about the sort of physical side, and that's sort of the obvious one, but looking at other ways that the energy system can be drained. And I think it gets a little bit overlooked sometimes, the impact that social fatigue can have. Often people suffering with long COVID say, you know, they've just gone out and had a drink or a meal with some friends and they feel exhausted afterwards. So looking at other ways that the energy system may be diminished, and the cognitive fatigue. They think that maybe watching TV or reading, and someone that's suffering with real severe fatigue, with things like post-exertional malaise, these are absolutely crucial in terms of helping the energy system restore itself. And that emotional energy is a real big one. When the athlete's losing, days are going past, weeks are going past, months are potentially going past, you can imagine the stress that that's going to have, the emotional drain again. So helping the athlete to be able to recognize these is really important. And, you know, I think people often say, so, you know, the big question is when's the right time to return to exercise? And it's really individual, isn't it? And it's about watching and seeing how the body responds to the exercise. So looking at the period of time after they've exercised, how are they feeling? How did that go? How does that compare to normally how you feel after that session? And so often it is about reducing intensity, reducing duration, and again, getting perhaps a bit more time between the training sessions, but using these tools of getting the parasympathetic nervous system back to help with the recovery. So this is a graph that basically sort of looks at someone over 3 days. And this is someone that is potentially, you know, not able to activate their parasympathetic nervous system at night, or it's not being activated, I should say. And over 3 days, their energy resource is going down. And so what we find is by actually getting that parasympathetic nervous system back through breathing, through relaxation, you start to see the recovery, and the energy system, the resources over 3 or 4 days is now starting to recover. And this is just with simple breathing techniques and relaxation. So those that are really suffering with energy, low energy and fatigue issues, this is really important. But I think what a lot of athletes might find is that it's not so much the breathlessness at rest or the fatigue, it's actually more when they exert themselves and it's high intensity levels that they might be struggling. It's when they reach the top of their intensity that there's a problem. So this is where it's really important for us to look at the biomechanics of breathing. And we often see if someone's had a period of time where they haven't been able to train or be able to really get their rib cage moving. Two things I tend to see. One is a rib cage that is very tight and can't expand, or the opposite, where the rib cage is overexpanded. So often I think there was a lot of news, wasn't it, with long COVID about doing lots of deep breathing. And you can imagine, people want to do these things to help them recover, and they do so much of it that they actually end up overinflating their lungs, and you almost need to deflate them again. And because, you know, an overinflated lung is just going to make that diaphragm be in a poor biomechanical position. And so we know if the diaphragm isn't in an optimal position, when it's contracting, it's going to fatigue. And a possible reflex that we think could be happening is that the respiratory muscles, when they start to fatigue, the reflex sort of with the peripheral vasoconstriction, so basically the lower limb muscles unfortunately don't get the blood. The blood is diverted up to the respiratory muscles, and so the respiratory muscles will always trump the lower limb muscles, and this is where the athlete's on maybe their 7th or 8th rep, and the pace is dropping, breathing pattern, losing their breathing pattern, they can feel themselves going, and the upper chest breathing is happening. We see this a lot. So really important that we get the good biomechanics of breathing to get the diaphragm working optimally. So a way of perhaps you recognizing if this is happening is obviously at high intensity exercise. You're going to watch the breathing. You're going to watch and see, is there nice movement of the whole of the rib cage, or you're seeing that upper chest sort of shoulders moving excessively. But that can be quite difficult in certain sports. And so it might be another way is to listen to the breathing. And what you'll hear is a really strong inspiratory almost snatch at the breath. It's a gasp that's almost sounds, I want to say the word desperate, but it does get a little bit like that for these athletes when they're really struggling. And what happens is it's just a really inefficient inspiratory gasp. And then there's not enough time for the expiration to happen fully because the respirate is so high, and they get into all sorts of problems. So ensuring good rib cage movement, really making sure that the athlete is breathing properly. These are all things that can really help the athlete when they're, during high intensity exercise. I just want to touch on for my last slide, or last couple of slides, is really important. If any of you, I'm sure you'll know about Professor Steve Peters' work, looking at the chimp management. You know, we think about breathing, and there's an emotional side to breathing, isn't it? You know, when you're excited, when you're nervous, when you're scared, when you're upset, this changes your breathing. And suffering more on COVID is going to really wind this up. You know, not being able to train is going to cause problems. So it's just a lovely way of understanding how the brain, I'd briefly describe it, but basically it splits it into the human brain, the computer brain, and your chimp. And your chimp is your emotional brain, and your chimp can basically have a full-on tantrum if it's not coping very well. And so it's understanding how to control the chimp. So sometimes we have to look at this as a way of helping athletes to manage their physical symptoms by keeping control of their chimp, and it's an important part that mustn't be missed if you find that the athlete's struggling with their breathing and their recovery. So to summarize, my work that I'm doing to enhance the athlete's recovery is really about good, efficient breathing. So it's getting the breathing back to what we want it to be, normalizing breathing, but also using breathing as a way of really helping the athlete to rest and relax. And as I say, promote that good balance between the sympathetic and parasympathetic nervous system. We have the tools to be able to teach athletes to do this. It can enhance the sleep and really help the body to recover and be able to then hopefully return to their exercise, their training more swiftly. Okay, that's me.
Thank you, Julie. Plenty of questions coming in for you afterwards. And the audience will have noticed that I didn't give any bios for any of you previous speakers because they're all smart enough to go to the ICH website and find them. But I will give a bio now for Miss Oonagh Cousins, who's going to be our next speaker. And Oonagh is part of our patient voices, and we think that actually this is the direction of travel that we need to move in as clinicians, to try and unpick and decouple the effect of what's physiologically, medically wrong, but actually the athlete is still presenting with symptoms that are clearly important to them and important to the performance directors and the PDs that we work with. And so Oonagh Cousins is part of the Women's Great Britain rowing team since 2019 and is a member of the University of London Boat Club. She raced the pair with Anastasia Posner in the 2019 World Cup and was part of the GBR2 Women's 8 at the World Cup. And then in March 2020, she was selected for the Women's 8 for the Tokyo Olympic Games. But later that month, caught COVID, had a very protracted illness, and unfortunately missed the Tokyo Olympic Games and is on that return to play continuum, which we are discussing this evening. So Oonagh, I won't steal your thunder any more than that, and then we'll have a group Q&A at the very end. Thank you for joining us.
Thank you very much for having me. Yeah, so that introduction was pretty good. Did a pretty good job. Just to give some context, I caught COVID in March 2020 and I basically took a break from training, and I am still managing the fatigue from that illness. As a general summary, I have seen this like very, very slow progression, and I'm now at the point where I can do kind of like 3 small sessions of exercise in a week. So I'm obviously still pretty far from what I used to be doing. Previously, I was doing kind of 30, 35 hours of training a week. So I've still got some way to go. But yeah, I'm here to talk about kind of how I've experienced the long COVID. I haven't really, my heart has been cleared, my lungs have been cleared. I don't have anything seriously wrong with those. I've just really struggled with the fatigue. My breathing is slightly off. I'm working with Julie. I think she would say it's not too bad, but there's some work to do. But basically what I'm managing is this fatigue. Yeah, and I've broken the phases, I've broken it down into 5 phases, and the distinction between the phases is not discrete, like it's kind of a general progression, but I can see in hindsight I've kind of experienced these phases, and that was the best way to explain it. So first phase was the initial infection. I actually trained with COVID. I can see now I trained with it for a month, and that probably wouldn't happen now, but yeah, it's important to say don't stop training, basically. I wasn't very ill. If I thought I was ill, I would have stopped training. I just developed like a cough, but we thought I had asthma, and I started taking an inhaler. I put fatigue on there. I can see now that I was starting to get tired, but with training, you feel tired. So it was very difficult to differentiate. Ended up in the last week before I stopped, I got an eye infection and I lost my sense of taste and smell, which now we know is obvious COVID symptoms, but at the time we didn't know that. So then sort of after about a month of training with COVID, I stopped, and that was when I moved into the next phase. And this was a period of 3 months, which I would say was really, really intense fatigue, basically. Everything was difficult. I struggled to cook 3 meals a day, and I had really, really bad brain fog. I just, like, normal functioning as a human just stopped, basically. You have this like really intense stress response to kind of very normal stimulus, like kind of calling a friend, you'd feel very, very stressed out. And it's the whole time I also had this very serious brain fog, and I didn't realize what was happening, basically. I kept telling people I was feeling better. And I think it's important to say that because I was really, really ill and I just didn't know. And I think athletes, I just thought I needed a couple more weeks, just need a couple more weeks. And I actually couldn't, I was like barely able to get out of bed. And I'm not someone who like tries to be this tough cookie or something. I honestly didn't realize how ill I was. It completely messes with your ability to read your body and just kind of work out what's going on and communicate how you feel. All of those things go out the window. The fatigue just completely stops you working as a person, basically. And also, as Julie discussed, the insomnia, you're like asleep for, I might sleep like 7 hours, but I would wake up not feeling rested at all. And now I can see that my parasympathetic nervous system just like wasn't working, basically. I just was like always switched on. My period stopped. I had no appetite, very easily overstimulated. So like just kind of like going into a room with like 4 people, you kind of like start to feel quite anxious. Lack of temperature regulation, quite nauseous, bad gut, and I've also put crashing on there because as well you kind of have this general like bad feeling, but you also have these ups and downs, and sometimes like you feel worse than other days for kind of no apparent reason. So I split each phase into kind of symptoms I was experiencing and then kind of key lessons from that phase. And I would just, if anyone is going through this, I would just say like complete rest, obviously no exercise, but try and reduce anything you have to do to a minimum, basically. Try and surround yourself with people who understand what's going on so that they can help you out. Minimize any kind of stress. I found that even communicating with people how I was feeling, looking back, that really stressed me out, and I like should have realized that was like not good. And it was probably a good thing to like try and describe to someone that this was stressing me out, but I just thought I was down because I couldn't train, but actually the illness was like meant that I didn't even have the energy to communicate how I felt, basically. So that is the kind of level of like minimizing the stress that you need to have in your life, if possible. Obviously these things, it's not always that easy to reduce the stress, but if you can. I put very gentle routine if possible, because like if you just stay in bed all day, like it can be hard, it can make it even harder to sleep. So like a very gentle routine, I mean like literally try and leave the bedroom in the day so that you kind of have some idea of what day is and what night is. And then be kind to yourself. I think the mental health in this period is really important. The fatigue really talks. So I was talking to a psychologist and we were talking about, anxiety and stuff, but it's a very physiological anxiety. Your nervous system is super wired up. You've got cortisol running through you, and that's why you feel anxious. Like there's plenty of reasons, external reasons, but I think that like if I'd known that it was the physiology that was making me anxious, that would have been quite powerful. Like we were talking about, the fact that I was anxious because I couldn't train, but actually I was just super wired and I couldn't relax, even though I rationally agreed, I've got plenty of time to the next Olympics. It just is understanding with the mental health that it's the illness that is causing the mental health difficulties, and you're physiologically struggling, and that affects how your brain works, basically. Okay, I think that's phase 2. I'm sorry, I've got a lot to say, so I'm trying to whiz through. And then phase 3, it was around July time. It started this kind of, the worst of the fatigue started to lift. And I was still very, very fragile. but I just started to have a couple of hours in the day where basic activity became a bit more manageable, and like just like the very worst of the symptoms and the most intense ones started to subside, and I started to have like slightly better days, and like the brain fog just started to lift a bit, and yeah, it basically just gets slightly better. And I would say from this point, you can start to put in some management strategies a bit more. And I think the key thing is just finding a baseline for what activity you can do sustainably, because the aim is to basically avoid these booms and busts, and the busts are really like difficult to manage and you feel really rubbish. But if you can find a kind of, you know, if you say, right, I can do an hour every day this week of stuff, and you then you can kind of like feel less bad, you can find kind of a sustainable level to exist at. And by staying within my means, I kind of very slowly but surely saw an improvement, and I avoided the worst of the symptoms. I mean, in July and August, I still had quite bad symptoms, but I just kind of gradually, surely, but yeah, like just started to get better. And by staying with my means, it makes it so much more manageable to like deal with the disease, and you can function normally in just like kind of much reduced hours, basically. What have I said? Yeah, I would say like pay really close attention to the red flags. So I've had to learn, and I think being an athlete, you're already kind of good at this, but you learn to like really closely listen to your body, and like really pay attention to the red flags. So the fatigue, your body tells you, and there's like red flags. For me, it's like I start to feel a bit nauseous, or I start to feel a bit fight and flighty, or I start to get a headache, or my appetite starts to go, and you can know when you're starting to overdo it before you overdo it. And it's important to pay attention to that to work out where your baseline is, basically. And also the other thing I would say is like pay attention to the accumulation of activity, because you can maybe have 3 good days, but then if you do lots of things on those 3 days, by the 4th day you'll start to feel bad. So you have to be careful that you're doing sustainable activity, not just what you can do on one given day. It's like pay attention to the whole week. And also the other thing that makes it difficult is that often the reaction to overdoing it is the day after. So in the morning, you'll know whether you've overdone it or not. I think there's a delayed reaction quite a lot with the fatigue, as it takes like some time for your body to react to it. And that can make it difficult, but if you pay attention to it, then it's quite useful. Yeah. I also, importantly, started taking 20 milligrams of citalopram at this point, and I think that really helped just kind of take the edge off the symptoms, and it just like started the process of starting to feel better. So yeah, I would recommend that, but I'm not medical. And then I also want to say that the menstrual cycle, my menstrual cycle has been a really important part of this experience, and my symptoms have definitely followed the menstrual cycle. So when I have my period, I feel a lot worse, and my periods have been heavier, and I've had quite bad cramps. And just in general, my period has been a really useful indicator for how I'm doing, and it shows me like over this period of time, my period has like slowly improved, and that's kind of given me confidence that my body's improving. So yeah, I think your menstrual cycle is a really important part of working out how you feel. Okay, I'm going to run out of time, so I'm going to move on. Phase 4. So from January, I started to get some kind of feeling of restlessness on occasional days. This was like very rare at the beginning, and this was kind of the first time when I thought maybe I'm able to start doing a little bit of exercise. And I want to say that at this point I still wasn't doing necessarily doing full days of normal activity every single day. So it was before I was feeling fully better, but my body just started to feel a little bit restless, and just on occasional days, and I kind of just started to do a few little really, really short jogs, and I found that quite helpful for just a bit of regulation, and it helped me to sleep. At this point I'm still very, very far from doing any training. It's not about training at this point. My body's still very far from being able to positively adapt. But it was just kind of a helpful means of getting better, basically. The same rules still apply. Find a baseline that works, and listen to your body really, really carefully. Yeah, and so from that period, from January to June, I went from doing 3 times 3-minute runs to kind of once a month to kind of every week I was doing 2 or 3 sessions, maybe 3 times 10-minute running. And and it was over a period of 6 months, and I just kind of very carefully tried to listen to my body and stay within my means, basically. At this point, still very far from training, but able to do a little bit of exercise just to help me feel better. Okay, final phase, and this is the phase I'm in now, and I would say I'm starting to feel more robust, and I can commit to a certain number of sessions a week. And although the difference between the good days and the bad days is massively reducing, I feel a lot more just resilient, basically, and my body feels like it can tolerate exercise on kind of good days or bad days. And when I say bad days, they're not that bad. And so basically that means I can commit to a program. And I'm still working this phase out, yeah, at the moment I'm doing a 4 times 10-minute bike twice a week and a 2 times 10-minute swim. And yeah, I have to pay it. Basically, I'm very, very slowly increasing that over time, and it's helping me feel better, basically. And so the things I pay attention to in order to monitor how much exercise I need to do is how I feel when I'm doing the session. So if I feel good doing the session and I feel like it's really easy, then I might increase it the next week. How I feel the following day after exercise, this is the most important signal I find. If I've overdone it, I'll know it the next day. If I haven't, if I feel good the next day and I have energy the next day, then I can probably good to increase the following week. And then also accumulation of tiredness at the end of the week. So I'm exercising Monday, Wednesday, and Friday. And if I feel really sleepy at the end of the week, then even if it's not post-viral symptoms, if it's just sleepiness, I still won't increase the following week because I've accumulated too much tiredness. Yeah, so I kind of use those 3 different factors to kind of work out if I'm good to increase the following week or not. I try to avoid as much as possible any post-viral symptoms. If I've got post-viral symptoms, I'm using reserves I don't have. But a little bit of good tiredness is, is okay. I think that's everything I wanted to say. Yeah, thank you very much.
Thank you so much for giving us your trust and giving us your story. You know, it's been an incredibly challenging time for you, and I personally, Matt, I'm very grateful for that. If we can get everybody up on the screen, please, John. Here we are. And Jim, I know you've got a couple of questions for Oonagh. I know we don't have a sports medic here this evening, and I know that's part of the key relationships that you have of supporting the athletes' return to play in that continuum. But I know you've got a couple of questions for Oonagh to start off with.
Yeah, well, listen, first of all, thank you, Oonagh, for your time this evening and for sharing your story. I know it's been a long journey with a lot of downs as well as ups, unfortunately turning a corner now. One of the questions I often get asked is, what is the risk if you try to return into exercise that you can just become simply over fatigued, or you become, you develop much more malaise from this? There's a lot of talk about not pushing it too hard too soon, and we spend a lot of time chatting to athletes about that. Are there markers or things you've found that have just simply been evident when you've tried to get back to things and you've perhaps pushed it too hard? What can you advise?
Yeah, so I've had a couple of a few bad experiences of overdoing it, and I mean, even in October, which is looking back now, I was still really ill then. I did 2 weeks of training. I think I did 2 weeks of a session every day, which I think shows you how much you can do before really experiencing bad symptoms. And then I ended up crashing really hard. And when I say crashing, I just feel really, really nauseous, very lightheaded. You have to lie down, you have no energy, your fight and flight's going crazy. You're feeling you just feel very, really, really on edge, and you just feel really ill. I can't explain it. It's just so different from tiredness. It's you just feel really, really ill. And then I've had a couple of other experiences since that time where I've maybe not crashed quite as hard, but I've kind of done little crashes, and those have helped. And those kind of built a picture for me of where my baseline is. And now I'm really careful to avoid post-viral symptoms, because as far as I'm concerned, I can't do full-time training until I'm fully healthy. And so if I'm still bringing on symptoms, then my body's not ready to do any kind of training as such. I'm doing exercise within my means to help me get better, And so therefore I stay pretty far from any post-viral symptoms. And my kind of early warning signs are the next morning feeling a little bit nauseous, losing my appetite, bad gut, those kind of things. And they're like, they won't be bad, like they'll probably pass, but for me, that's my red line. I won't, if I've done that, then I've done too much the next day. I mean, the previous day.
Okay, thanks very much indeed. Back over to you, Matt.
Yeah, so Jim, just on that point then, really. So in your, and for Guido, in your clinic, you've seen many professional athletes come in now where an athlete may have had moderate symptoms. It's been a couple of weeks now, and the club doc has said, look, we just want the all clear. The athlete's being checked over by you guys, nothing really wrong with the heart and lungs from what you can tell. They go back. What sort of advice are you giving to the team physician at that sort of early stage? You say, this is what they can and can't do.
Guido, do you want to go first?
Well, yes, I would usually go firstly, we would assume that we have excluded any cardiac symptoms. And of course, time is on our side. The longer you are without cardiac symptoms, the better your prognosis and the less likely you will develop some. So usually the easiest thing to have is really heart rate in terms of sessions. We do know that very intense sessions in particular, in general, are, if there's a predisposition for any arrhythmic event, then high intensity sessions or long endurance sessions are not the ones one should do. So if there is cardiac involvement, mild cardiac involvement, be it some mild changes in cardiac function, I would usually say it usually takes 4 to 6 weeks to get back into match fitness and into selection mode when you talk about football. So this would need to be taken into account. So usually what I've done with the athletes I've had is starting in the first week to do really some exercises in terms of fitness, stability, not too high intense, and always look at the heart rate. And often we will have done a cardiopulmonary exercise test, so we know what the maximal fitness is. We know where the anaerobic threshold is. So for the first week, I would not go very often over the anaerobic threshold. And then I would build this up over the next 2 weeks. And heart rate monitoring is quite good. Of course, all athletes, most athletes will have a heart rate monitor on. This is also an indirect monitoring tool for arrhythmias. If I have a suspicion of arrhythmia, I would, after 3 to 4 weeks, do another mobile Ecg monitoring.
And Jim, from a respiratory perspective?
Yeah, I mean, so fortunately, we've not seen longer term serious consequences in very many athletes, and vanishingly rare to see, for instance, blood clots or scarring change on the lung. So, I mean, our role really is principally to, one, make sure the tests have ruled out anything significant in the lung, and also to consider other things which might be contributing, to rule in abnormalities that we can help with, for instance, as Julie's talked about, and breathing patterns. And the third thing really I see is to try and help manage expectations. So I presented some data early on that suggests that, you know, the prevalence of individuals who are not fully returned at 28 days in an elite sporting system, which is heavily supported, is still about 1 in 4 individuals. So, you know, that gets better over time. There are cases, of course, where it goes much longer. But if you can help manage the expectations of the athletes and the coaches, that this will get better, it will just take a little bit longer than you would expect for a typical respiratory tract infection. I think that's helpful, especially helpful for mental health as well, when people expect us to bounce straight back after 10 days to 2 weeks, and they're struggling a bit.
Matt, if I can just say this as well, though, however, if all the cardiological tests we've performed are normal, then I do not see a reason to hang around for a long time to anticipate a potential cardiological risk. I mean, if you do the tests and they're normal, then there's no cardiac involvement, and then there's no particular cardiac care to be taken.
Okay, cool. We've had about 30, 40 questions come in, and we've grouped into sort of 5 or 6 areas. And this relates back to one of Oonagh's first points, is about, you know, we've learned a lot, the evolution of COVID and the symptoms and the time course of that, and routine testing, lateral flows, PCRs, etc. One thing we didn't really cover in our guidelines is what to do with the asymptomatic athlete who is PCR positive, and about whether they should be withdrawn from training. Obviously, they're going to be isolated, but telling athletes to rest when they feel perfectly well, but they're actually PCR positive. What's your sort of general advice on that area? And I know that's particularly relevant because I had a few questions from the military doctors on it, saying you haven't really covered that in your guidelines.
Over to you, Jim.
Thanks.
Pass the buck. Bosh. Oh,
Thanks,
first
Guido.
one in.
So I suppose you have to really go back to how we first came up with a decision tree, which said, look, if you've got mild COVID symptoms, I know this is slightly tangential, then you would recommend a period of time where people don't partake in intense exercise. And the reason that 7-day period and 10-day period came up initially wasn't for fear of some cardiac abnormality or other issues like that. It was really the fact that we developing some intelligence from the data that was coming out of Wuhan to suggest that this seemed to follow a sort of biphasic course, this illness, where you could initially be quite well, and then at about somewhere between 5 and 7 days, you would develop a much more serious illness that was at that point rendering you in need of hospital care and hypoxemic at that time. And that was the condition that really flared up the inflammatory system. So my advice would be that we're going to see a lot more so-called asymptomatic PCR positives, especially in those who are double vaccinated, because there is carriage, but there isn't necessarily translation into illness. And so I don't think it's unreasonable to continue to exercise, but to reduce the intensity and maybe not to be partaking in very vigorous exercise for fear that you may be in the early stages of then developing the illness that then becomes manifest, 48 hours later. And that would be my take, and reasonably light activity until you're to a period, for instance, of 4 or 5 days out from the diagnostic test, in which case you could then start to ramp it back up again. I realise that isn't supported by data that's out there to date, but that would be my perspective.
Guido, anything to add on that? No.
I'd agree with you, Jim, and that's why I do bank a lot on symptomatology. So are there really symptoms of being ill, having been ill? Because don't forget, we can make COVID into a very special virus, but we see myocarditis from other viral infections as well. And if we tested for those, we would clearly have a proportion of athletes who are positive, and this would not and has not resulted in cessation from exercise. There's, however, a point also with the COVID vaccination that although there's limited data available to suggest that 24 hours afterwards one should not, and this is a general, not only athlete advice, one should not engage in strenuous exercise. And this goes back to the same rationale, which is, however, not evidence-based, that Jim elaborated on.
Okay, great. There's a couple of questions coming in now, and forgive me for saying this, but good breathers and bad breathers. But in terms of ventilation rates, the big endurance class of populations versus more team sports, strength, power-based sports, for the athletes coming through, Julie and Jim, do you find that athletes who had high ventilation rates, big endurance sports, do they tend to be the one? And if they have a protracted illness, is this a cohort that is particularly challenging in their return to play, their breathing patterns, etc.?
Julie, over to you.
I do think that we often see those athletes that have high minute ventilation, those endurance athletes, when their breathing is bad, the high minute volume, so the high excessive air going through the lungs does cause that drying effect. And so I think there does seem to be probably definitely with breathing pattern disorders does tend to be more prevalent in endurance athletes. So do you agree with that, Jim?
Yeah, I think it's difficult. And I mean, obviously there are certain sports where breathing has to do very unusual things. I'm thinking things like swimming and rowing, where the breathing pattern is up and down, and that has to depend on different thoracic movements. So, we tend to see, certainly out with COVID, higher prevalences or issues potentially where the breathing is challenged in different ways simultaneously. And that's a particular challenge, I'm sure, for Julie to try and help those athletes control their breathing when it's very complex indeed.
Yeah, that's right. And just, I think, you know, just making sure, so I know I talked a lot about breathing at rest, but making it sport specific, like you say, you know, the breathing pattern for the swimmers can be very challenging when they're at high intensities. They're not able to, you know, the respirate is actually controlled, but then, you know, that gasp of air that comes in very quickly needs to be made sure that it's a really good rib cage movement, which, as I said, that's often what we see is those changing in biomechanics can influence that. So yeah, I think you're right in terms of the different sports. We do need to be making sure that we're sort of addressing it, be very sport specific with the breathing pattern retraining.
Gentlemen, we've had a couple of questions about the vaccine, particularly from a performance perspective and from a side effect perspective. Jim, I know you've published some documents on this. Obviously, we want to try and convey as many people to get the vaccine as possible, but from a symptom-based and from a training-based perspective, what would your advice be to that pop?
Yeah, I mean, we haven't actually published that yet, but hopefully we'll.
Sorry.
No. So, but hopefully that will appear soon. Essentially, we've prospectively tracked symptoms in again an elite cohort who've been vaccinated, and generally the top line is it's very reassuring. So we haven't encountered serious side effects, and the most common side effect, as you might expect, is a sore arm, which is of course relevant if you use that arm for sporting participation, but it generally speaking resolves within 2 to 3 days, and some mild fatigue. But you know, the overall impact in terms of a protracted impact on ability to continue to train is very low indeed.
Okay. And then we've got got a couple of questions just on the, you know, it's interesting to see the transition between chronic fatigue and the terminology they use of a paced return rather than we say, you know, in the sports world, the graduated return to medicine, a return to fitness. It's interesting to see the synergies between the two areas. The question that I have is and I've already said we don't have a sports medic here, but Oonagh, you've consistently said throughout your talk about mental health and the ability to speak up to someone and convey, because what I'm hearing from your talk is after you've been to see us, essentially you were told there's nothing really wrong with you. But clearly you've been on a 18-month journey where there has been something clearly wrong. So if I could put the question back to you, what is it and how is it you would see that our service, the sort of the sports cardiology, the sports respiratory, the breathing physiotherapy, in hindsight now, how did we do in conveying that sort of message to you, and how do you think we could improve that service and improve the information that we deliver to you?
Oh, it's a big question.
I know.
Yeah, no, I mean, it was really reassuring to know that my lungs and my heart were good. Do you know what I mean? Like that's like a big box ticked. And I think I was aware that like fatigue is not something that's like medically understood. And I had that conversation with the doctors, with you guys, and we knew that my lungs and my heart were fine, but we, you know, there was like a mutual understanding that that didn't mean I was better. So yeah, I guess in terms of the mental health thing, it's just a part of it. I think Julie talks about it. It's this kind of like the reserves that you have as well. I think it just needs to be discussed, I guess, more maybe. But I guess the thing I want to say, I tried to make that point in my talk, is that it's very physiological, the mental health thing, and I think understanding that is really key. And it's something that I think I have been able to understand because I did biology at uni and I did neuroscience and psychology, so that helped, and I had an understanding of what was going on. So I think that's been quite powerful for me, because I have been able on those bad days to be like, well, I know my body's just kind of freaking out, like that's why my brain is telling me these things, and I can wait those points out. So kind of maybe that's helpful, I guess, like knowing that knowledge is power. But yeah, I don't know, does that answer the question?
No, it does. I think we're all on a learning curve with this, and you know, I'm really grateful for you for giving us your time. I think, you know, we as clinicians can learn a great can learn many more things from the patient experience and really trying to delve deep into that. So thank you for that. We're going to wrap up now. And so I thank all the speakers for their time, and I thank Oonagh for your time as well. This lecture is completely free. It will put up on the ICH website along with all of our other webinars that you can download and distribute accordingly. And after, I'll try and get Julie to, well, not I try, we are producing some videos at the moment on what good breathing technique is. So give us a couple of weeks on that, because we've got to get the camera crew in and make Jim look good with the makeup. And then they'll be online as well. So thank you for everyone's time this evening and have a great evening.